Okay, so we now move on to the keynote speech. So I'm going to introduce Dr. Antonio Baines, who will introduce the speaker. Dr. Baines was one of our first external advisory board members who initiated this conference 10 years ago. So we're truly, truly grateful to you, Antonio. He completed his Bachelor's of Science in Biology from Norfolk State University. Then he did a PhD in pharmacology and toxicology at the University of Arizona. And then following that, he did a postdoc, and then he joined the faculty at UNC Chapel Hill. But he's now a full-time faculty member. He's an associate professor in the Department of Biological and Biomedical Sciences at North Carolina Central University. He will be introducing the keynote speaker. Thank you.
Good afternoon. Good. I'm trying to pump you up for the keynote speaker. I want to thank the organizers of this symposium. I've had the honor to do this, to be here for the past 10 years, serving on the external advisory board, and just to see the growth of it over the years has been very humbling. And so just want to thank the organizers, Mauro, Lauren, and many others behind the scenes that have made this work. I was just having a conversation earlier that I think what makes this symposium very special is that it includes not just, the thought leaders, the scientists, the physicians, but it includes the public. A lot of times we do all this, but we're hearing the same information between our colleagues, but to be able to make sure the public's involved, I think it just makes it that much more special and gives it the application it needs, because it doesn't matter all the discoveries you do in the lab if it doesn't get out into the community. What does it matter? So I applaud the organizers for doing this. We've had some great keynote speakers over the years, and we definitely have a great keynote speaker today. Quite honored that she took time out of her busy schedule to come and talk to us about her research and her passion for health disparities, health equity, all the great terms that we are enjoying in this interesting climate we live in right now. So real quick introduction. So we have today Dr. Chanita Hughes Halbert. She is the Vice Chair for Research and Professor in the Department of Population and Public Health Sciences at USC, University of Southern California. She also is the Associate Director for Cancer Equity at the Norris Comprehensive Cancer Center at USC, University of Southern California. She has a BA degree in psychology from my rival HBCU, Hampton University. We won't get into that battle right now because we try and keep it professional, but no, we're good. Just my school's better, but just saying. And then also she has a PhD in psychology from Howard University. So definitely have some awesome HBCU exposure. She is definitely someone to know when it comes to health disparities and health equity. She was a member of the Board of Scientific Advisors at the National Cancer Institute and the National Human Genome Research Institute Advisory Council. Dr. Hughes Halbert is a past recipient of the AACR Distinguished Lecturer in Cancer Health Disparities Award and is a member of the National Academy of Medicine. Again, I know what's going on in this political climate we live in, but at the end of the day, we still need to have a focus on health disparities, health equity. And I cannot think of a better speaker to have for this 10th year anniversary of this symposium than our current speaker, keynote speaker today, Dr. Chanita Hughes Halbert. Please, let's give her a big hand.
Well, good afternoon, everyone. I'm really excited to be here today and would like to also start by thanking the conference organizers for inviting me to come spend the day with you. I'm excited to be here. I'm sorry I missed the morning session. I was a little bit jet lagged from coming from California, where it is still morning. I'm really excited to be here and have some conversations with you about translational research and cancer health equity. And I think we have to continue having these conversations, particularly at this time when the work that we're doing is really being scrutinized and challenged. And I think this is just an opportunity for us to show resilience so that we can maintain our impact and improve the lives of our communities. So I wanted to start with a couple of things just to kind of set the stage and the background. I mean, I think one of the issues that has always been at the forefront of my mind, has been at the forefront of your minds, and really at the forefront of our institutions that have invested and will continue to invest in minority health and health equity research is that we really do want to create the opportunities for individuals to live their best lives possible. That's a goal for Healthy People 2030. It's one of the ways that we think about that is how do we remove the systemic barriers that reduce access to care, that reduce the quality of care that patients and our family members and communities receive. But then also, how do we enhance a high quality of life following those treatments? So when we think about this, it's really about ensuring justice and equity. What's been really important, I think, over the past couple of years is we've begun thinking about not just the care that's delivered within the context of the clinical space, but really how the broader lived experiences that we have, how that influences disease risk and outcomes. And so that's sort of shown here under this rubric of social determinants of health, which is really, I think, a way to describe a lot of different things that happen in our day-to-day lives. What I think is important about social determinants of health is that, one, when we sort of consider it within the context of clinical factors, we consider it within the context of genomic and biological variables, that the social determinants actually are very important for us to consider. That's not to say the other issues are not important, but I think where we're going now as a field, as a group of investigators and healthcare providers, is that we're really wanting to understand the intersection between our lived experiences and then these sort of other indicators related to biology and healthcare delivery. And that's because the landscape is really changing. The landscape of cancer health disparities is really changing. So when I started my career many years ago, we really focused on Black-white differences. But now, and that was really the framework in which we really thought about cancer health disparities. But now we have more communities, more diversity within our geographic areas, within the catchment areas for where we deliver healthcare, and where we implement strategies for disease health promotion and cancer prevention. We also know at the same time that there are issues related to geographic variables that influence our exposures to environmental contaminants. There's also issues around how individuals sort of live within the context of their communities. So all of this to say is that as we sort of become more diverse, we have a better understanding, have better methodologies for incorporating understanding of these different types of drivers, that really changes the landscape. It makes it more complicated for sure, more complex to understand, but it also, I think, creates an opportunity where there's more room for all of us to be at the table to combine our efforts to enhance cancer health equity. So what I'd like to do is give you a couple of examples from my own research and from research of others where we've really begun to dig down deep to understand sort of and dissect these multi-level drivers of cancer risk and outcomes. And I'll start with breast cancer, mainly because I think it's important just to sort of continue the conversation from the previous presentation. So you've heard about breast cancer disparities from Dr. McCullough, my colleague, and the work that the American Cancer Society is doing to really create the resource for us to begin to from an observational perspective, to understand some of the drivers. But I think what's important, the message that I want to convey is that even in the year 2025, we still see the same trends in breast cancer disparities between African American and white women. We also know that in some parts of the country, that we have lots of different women who experience disparities in terms of disease risk and outcomes. This is work that was led by my colleague, Dr. Mariana Stern, and using the cancer surveillance program that's available at the University of Southern California, we're able to really sort of drive down and sort of translate these bars that are shown on this side of, I'm like, can't even tell my left from my right now, but the bar graphs that show incidence and mortality, and really understand that based on geographic areas, because that helps us to say, well, we have women from different racial and ethnic groups living in Southern California and Los Angeles County in particular, but where does that translate into where they physically live, their physical address? And that's important because it helps us to begin thinking about where we offer health promotion and disease prevention interventions. It would help us to understand how we need to prioritize more observational and genomic studies and drawing from those populations that live in those communities. So when we think about combining that information, it's really powerful. And I think that has really been an important sort of message that has impacted the community, the broader community that's doing work in cancer health disparities overall. There's been a huge explosion of studies that have really sort of taken this notion of understanding geographic diversity, geographic residence, and linking that with genomic information, linking that with psychosocial information, linking that with clinical care and the delivery of outcomes. That's been so important. But what I want to emphasize is that geographic residence, when we look at it at the census level, is powerful and important, but we also need to understand it. We need to be able to really understand how people live in their communities. And that's really where the work of myself and others from a behavioral science perspective, and particularly translational behavioral science, comes into play. So if you think about sort of geographic residence, right, it's like we can use census information to determine sort of geospatial and geocoding, and that's really important. But what I think has become resonated in my mind is that, the social context and the lived experiences that are reflected in someone's housing instability, that's reflected in their unemployment status and history, reflected in their difficulty with finding a job, and issues related to violence and engagement with the legal community and experiencing legal issue, is really sort of is results from structural racism, it results from systemic racism, but those are all like really important life stressors that we are now learning has implications for disease risk and outcomes. I've been thinking about this from the perspective of how these issues are some sort of giving rise to new kinds of translational barriers and cancer health disparities, because I think, many years ago, we were of the mind that if we were to provide sort of greater equity with respect to obtaining healthcare insurance, that would address the disparities. And I think we've sort of got good evidence that that's not necessarily the case. But what we do know is that people live in their environments. People experience stress as a result of living sort of within the context of a long history of structural racism, systemic racism, and prejudice. But we also know, but we don't really understand how that sort of constant exposure to those types of stressors, the broad stress of structural racism, but really the individual stress that can be experienced, that both at the individual level, but also at the community and population level. What's really intriguing to me, and I think really important, is that, we have to begin to understand how the intersection between stress exposure, the biological stress responses, and mechanisms is really fairly limited. And that's, I think, an important space for us to begin thinking about launching a portfolio of research that's designed to understand sort of a translational strategy where we're really trying to link the impact between social drivers on biological pathways that are sort of activated and from disease initiation, progression, and response to treatment, but really focusing on those that are particularly amenable and through intervention in community, clinical, and public health settings. So all of that to say is, we want to understand, and I think this is where, that it's so important to have a transdisciplinary team, because as we're understanding these sort of multi-level drivers, the intersection between stress, exposure, and biological mechanisms, that we ultimately want to be driving towards and producing empirical data that can be translated into interventions, and interventions that are delivered in clinical, community, and public health settings. So some of the ways in which we've been structuring our research priorities around first characterizing the nature and distribution of social stressors and understanding how they impact and related to biological processes. We also want to understand that in relationship to cancer outcomes. So the cancer outcomes that we are particularly focused on include incidence, morbidity, and mortality. We also want to improve the ways in which we can use that as a basis for developing new research directions in cancer health disparities. And I'm going to share with you a couple of examples. You've seen the slides from Dr. Gaddy previously, but just to I want to introduce it here to show that, it really has this framework that our team developed, and there are other teams that have developed similar types of frameworks. But what's been exciting to me is that when we started doing this work, we sort of was like, these are really important sort of, the social determinants really sort of influence and impact these drivers that we can ultimately intervene on. These biological variables, stress responses are things that we can actually intervene on. So I became really interested in stress responses many years ago through work that was conducted through the Centers for Population Health and Health Disparities. It was a program funded by the National Cancer Institute, the National Institute on Environmental Health Sciences, and I also believe the National Institute on Aging. And they supported this research to really use a population-based approach to understand disease risk and outcomes, and cancer was one, cardiovascular was another. But a group of investigators that was part of this consortium did a really, I think, groundbreaking study, and it was relatively small, but it was important because I think it set the stage, where they demonstrated using an animal model that social isolation among animal produces a stress response, a cortisol response that leads to the initiation and progression of disease that's more similar that is similar to the histologically similar, that is, to the types of breast cancers that are diagnosed among African American women. So the question becomes, an animal model I think is really important, but then it's like, well, how do you understand that process in people? And then more importantly, how do you use that information as a way to develop interventions? So this just illustrates, this is I think a really important topic at the moment. And it's been developing, and I'm glad to see that it's become important. It has risen to the sort of a priority area, because it's actually the work in the Centers for Population Health and Health Disparities was done in like 2003. So, it takes a period of time for work to kind of, for the evidence to accumulate and to really be able to now have a framework where we sort of start with these broader social political structures and say, for some groups, some communities, it's very stressful to live in that structure, but that it has downstream effects, this gentrification, racial segregation, neighborhood environments have these downstream biological effects that we can study. And by sort of using this framework as a guide, we can begin to understand some things such as related to HPA axis functioning and stress response, is a particular thing that my team has focused on, but really begin to understand how that relates to molecular changes that are important to and ultimately lead to racial differences in breast cancer subtypes. It's also just, I'm a behavioral scientist, and I'm sort of learning biology, at this point in my career, which has been really exciting and really exhilarating, because what it sort of does is says, if we start with chronic stressors, it activates the HPA axis, and that stress hormone response really sort of plays a role in tumor development, plays a role in the initial and progression of disease and response to treatment. Now, many of you in the room are doing work related to the tumor microenvironment, related and sort of understanding inflammatory processes and responses. And I just want to make the plug that, I don't do this work alone. And so our team really includes that expertise to really begin to, understand the cascade effects that come from a stress exposure and stress response. But what I can do, and what we've really been focused on as a research group, is really trying to understand the ways in which social determinants of health, particularly as manifested in stress responses, are important and influence sort of disease risk and outcomes among African American women. This was an effort to bring together sort of dig down deeper. If you think of one of the things that we use as frameworks is sort of a multi-level approach where we try to understand drivers across multiple levels of influence, across multiple domains like individual, community, healthcare system, and then into the broader sort of social system. So we were interested in really diving down deeper within the sort of individual level, and then look at biological and behavioral drivers related to biological vulnerability and mechanisms. And biological vulnerability in this case is the potential for there to be a dysregulated stress response. And what that only means is that because of higher rates of chronic exposure to stress, the way in which some communities respond to stress, it doesn't follow the typical pattern, the pattern that we would expect to see. So we did this as part of a randomized trial that was supported by the National Cancer Institute. And our goal was to first characterize stress reactivity among African American breast cancer survivors, understand that relationship between stress reactivity and treatment compliance. Because if you can imagine, if you have a lot of exposure to stress, you're responding to that stress both physiologically and behaviorally, that has potential implications for the extent to which women might be compliant with treatment recommendations, as well as follow through with cancer control recommendations. We were also interested, though, in understanding that, people understand and respond to stressors in a different way. And so part of an empirical question that we explored in our randomized trial is that whether or not having a sort of an acute stress response that can be activated in the laboratory setting has implications for how women sort of prioritize their responses. And we did this through a measure called temporal discounting, which is whether or not women are one's ability to and preferences for sort of focusing on things that are happening right now versus future outcomes. And that's relevant when you think about cancer control behaviors, because screening, engaging in a healthy diet, meeting the recommended guidelines for physical activity, those are things that have some sort of things you have to do right now, but they have long-term benefit, and you sort of have to sort of view it from that perspective. And that's relevant for, it's been shown to be important for smoking, diet, physical activity in terms of one's temporal discounting preferences. So this is the methods, and I guess I just want to situate it in sort of this broader multi-level framework for stress reactivity, where in this study, we were interested in sort of understanding HPA axis functioning in a population of African American breast cancer survivors, but we also measured similarly within the study, acute stressors related to their clinical case. That means stage of disease, their length of diagnosis. We focused on African American women because we were primarily interested in addressing a population that has continued to experience disparities in terms of cancer outcomes. And then we also included a sort of understanding a neighborhood level in terms of chronic structural stressors. So social deprivation, neighborhood deprivation was the final level rather that we explored in this study. So what was also important is that, we were able to use a laboratory-based stressor to activate the HPA axis response. And so this approach is validated in terms of generating an acute stress response. And it's it's relatively straightforward to use. So what it involves is doing a math task and a speech task. And what it does is sort of activates the stress response. You can measure whether or not individuals have what's typical, which is like you have an increase in cortisol, which followed by a decrease. So there are a couple of different scenarios. You can have that pattern of response. You can also have the pattern of response where you're high, you're elevated, and you stay elevated, or no response, which is sort of the two different categories of dysregulation, where we sort of be concerned about how women are responding, because ultimately cortisol and having a stress response has benefits. It's tighter to the fight or flight mechanism. So you're exposed to something threatening, you activate, cortisol is elevated. It gives you sort of that extra boost to respond. And if you have to run away, this, in early times, it's like run away from something that was really threatening your survivability. But if you think about that sort of in a day-to-day situation, someone's cortisol level is consistently elevated. That has it's been shown to have long-term negative consequences on multiple systems. So we've been talking about clinical trials, and I wanted to share our enrollment data and illustrate a couple of points. So this study was done at my previous institution, which was also at an NCI-designated cancer center. And one of the things we anticipated, and we knew that recruitment would be a challenge, because recruitment always is a challenge, no matter what population, what group you're studying. So, we built upon our evidence. And what I'm glad to say is we built upon our own published work, where we learned that, there are two different strategies. You can use an in-reach strategy, where you sort of recruit from, identify participants from the existing resources. And the technology, the tools are now available where we can, query our electronic health records and identify individuals who meet the eligibility criteria, send out an invitation letter that invites them to participate in the study. And then from there, we can complete the enrollment outcomes as dictated by their responsiveness. We can also use an outreach approach, which is, recruiting through the study, through newspaper advertisements, through social media. And what I would say is that, for this study, because we were focused on African-American breast cancer survivors, we prioritized using an in-reach approach. So we identified women from our electronic health record data. We were also available in the breast surgery clinics on site, which was a sort of a hybrid approach, because it was in reach, but using an outreach mechanism. So all of that to say is that when we think about clinical trials recruitment, and we think about recruitment and cancer research overall, there's a strong and long evidence base about things that work and strategies that don't work. And so what I would encourage us to think about is sort of drawing upon that evidence to sort of design recruitment strategies that are the best fit for the particular scenario, but that also are informed by what we know is likely to work and not work, and where. So we knew we wanted breast cancer survivors. What we also learned, though, is that we really do have to tailor the messages to be the most salient. So there's a huge base on recruitment to clinical trials. There's a huge base, empirical base, about recruiting diverse populations to cancer research, just in general, that I think we want to be mindful of as we launch new research. So what did we find? We found, I guess the first thing that we found was that, negative life events, so that life context, and we measured that by self-report, is that they increase the likelihood of having a high cortisol level at baseline. This is before women were exposed to any type of stressor in the laboratory. So I don't think that surprised us, because we'd expect that if you're experiencing more stress in your life, that you're likely to have a higher level of cortisol, higher level of stress response hormone, just because you are experiencing more negative life events. I don't think that was surprising. What was surprising is that when we did a sort of a deeper dive into understanding some of the specific stressors that can be experienced related to financial strain, social isolation, general perceived stress, there were big, significant differences between stress reactivity, how women responded to that that stress exposure in the lab, and we think about doing a math task or a math or a speech task. They are sort of benign stressors. I mean, it's not like your life is being threatened, but we see consistent patterns of response where women who had reported any one of these stressors had an excess level of cortisol reactivity during the course of the stress exposure visit. So why is that important? It's important because it helps us to see that it's not just the overall life experience, but it's some of these particular stressors that are really important to stress reactivity. We also see that there are women who have these higher sort of consistent patterns if you're experiencing one of these particular types of social stressors. And that has implications for how we think about, well, what are the next steps for that? We can use this information, patient-reported data, to prioritize women who should be screened for these social stressors, because ultimately we're now, as healthcare systems are now required to do screen patients for social risk factors. That's happening. It's happening in a variety of different ways. That's an emerging area where I think there's opportunity to generate best practices. But if we think about that long term, these are some of the ways that we can begin thinking about prioritizing our data collection efforts. The next example I want to give to you is from work that we were doing, that we continue to do with the context of minority men's health. So a question was asked about, well, what are we doing about men's health? And I think that is so important because we know that African American men in particular have some of the worst national examples of exposure to systemic stressors, adverse life events, sort of at a national scale. And so with support from the National Cancer Institute and the National Institute on Minority Health and Health Disparities, we established a multi-regional consortium that was focused on doing translational research that was designed to understand the ways in which biological, social, clinical, and psychological drivers influence the initiation of prostate cancer, progression of disease, and response to therapy as part of this regional consortium that all was designed to disseminate and implement the findings within the clinical context. So why do we focus on men's health, and why, more importantly, did we focus on prostate cancer? So our rationale is shown here, one of which is that prostate cancer is one of the leading causes of morbidity and mortality among African American men. It was also what our community partners told us that we needed to be focused on, that they had a strong preference for understanding sort of ways to improve men's health. And when we think about men's health, particularly Black men's health, we think about prostate cancer. But the studies that I'm showing you on this slide illustrated a novel point, which is that regardless of men, these were all among this work was done among men who were diagnosed with early stage or locally advanced disease. And what we found was that men's response, their perceptions of stress was important to their overall quality of life. It was important to how they experienced their disease-specific quality of life. So it began to raise the question for us is that if these sort of general perceptions of stress are important to these sort of important cancer-related outcomes, quality of life is important cancer-related outcomes, then what's it like for men who experience just a different level of stress exposure in their day-to-day lives? So that raised a question for us in our minds, and this actually, we started thinking about this question again when I was at my previous institution, where it was one of the first examples where we saw, the violence and the stress that African American men experience just driving down the road. And so, we know that those are, I think, a unique experience that African American men have, and that those acute and chronic stressors are important to understand. And this was the first thing, and I was thinking what was meaningful to me is that it was the first time that we began to incorporate sort of the lived experience of a community within the context and let that drive our research focus and research question. So our goal for this was like, well, how do we identify and can we identify a marker that can be used across clinical public health settings to understand the physiological consequence of repeated chronic stress exposure? Allostatic load is that type of marker. Allostatic load is a reflection of how much social and psychological stressors impact biological functioning. It's sort of a biomarker that's made up of biomarkers of heart rate, blood pressure, body mass index, and some other indicators that are typically measured as part of healthcare delivery. And because we ultimately wanted to impact and drive sort of the work and the care that was delivered within the clinical context, we believe that it was an important sort of variable for us to understand as one of the key ways that we can understand sort of the physiological consequence of exposure to a variety of stressors, and really begin to amplify and build upon the previous work that demonstrated that racial disparities in allostatic load exist. But we really don't understand, how it influences disease processes and outcomes. There are a lot of measurement issues with allostatic load that I think are sort of impacting its ability to really be adopted as like an indicator that's used across healthcare systems to measure sort of the physiological consequence of repeat stress exposure. So this is, we started addressing that as like a key measurement issue within the study and have used a variety of different methods to calculate, measure allostatic load across men at different stages of prostate cancer care. So that's men who are undergoing a prostate biopsy, men who are undergoing prostate cancer treatment, have completed treatment, and then men who are long-term survivors who are at increased risk for recurrence. And what I want to share with you, I guess I took that slide out. What I will share with you in a forthcoming paper is that, we have some evidence to show that we can create an abbreviated score that has relevance to the broader score that I think addresses the measurement issues. So we're now at a point where I've talked about our research in breast cancer, which is really about understanding breast and prostate cancer, which is really about understanding the ways in which multiple drivers, particularly social stress exposure, influences biological mechanisms that are important to disease risk and outcomes. So as a behavioral scientist, one of the things that I think about, and I think all of us really think about, is that we want to develop interventions and solutions that are actionable and that can be sustained. And, the actionable and sustainability really resonates with me because typically behavioral scientists, we develop these really complicated intervention approaches that can't be implemented beyond sort of the randomized trial, and therefore don't have a strong chance of being sustainable in a clinical setting. I think the other thing that we have to think about when developing interventions and solutions is that we want them to be aligned with national, regional, and local priorities. And that could be local within sort of our community level, local within the healthcare system, could be local within the community. So we have to really begin thinking about tailoring our intervention and solutions to really the priorities that can exist among different sort of entities within, our sort of broader shared lived experience. I think the other thing that we have to think about when developing interventions and solutions is that they have to be targeted to the appropriate scope of influence. And what I mean by that is, there's some, one of the things that I think has been really important for me to learn over the course of my own career is that, there are things and drivers that our research will impact and will have direct relevance for. And those are things that we can do. And what I've been really so impressed with in the work that I've done with community organizations is that, healthcare systems can take time to develop their priorities. They'll take time to develop, what they want to do, but communities will move forward and they'll activate and implement solutions sort of regardless of what the healthcare system says are their priorities. So I just want to say that I think communities have a much more tremendous scope of influence, that if we were to partner that with work that's ongoing and the healthcare systems, then I think we would really, advance all of us to achieving our goal of equity. So I think but also at the same time, what I'm hearing more and more about, and what I think the conversations are happening now, is that clinicians are recognizing the importance of social drivers, social stressors. They're beginning to talk about it. The basic scientists are recognizing the importance of social stressors. We're beginning to talk about it. And so we're all having these conversations. We're talking about it here in this context. So we're having these conversations. The question is, well, how do we move forward with addressing them? A couple of things that really drive this is, are we able to screen and identify patients, community residents, individuals, healthcare consumers, whatever kind of level you want to describe it? Do we have a reliable way of identifying those who need help, assistance with addressing issues outside of the clinical context, but have direct relevance to the quality and outcomes of care that's provided? So this is where, I'm really excited, because we've been launching, with the support of the Ralph Lauren Corporate Foundation, a new sort of a community-focused clinical approach to addressing social issues and social stressors as they relate to cancer care. And so we've established the first Ralph Lauren Center for Cancer Prevention on the West Coast. And our goal is to support cancer equity in Los Angeles County. And our vision, our mission, is to enhance the uptake of high quality cancer screening services, and then also improve the access to timely cancer care within the context of patient navigation. So patient navigation is an empirically based strategy for addressing individual barriers to cancer care. Early work demonstrated that patient navigation has benefits in terms of reducing time to treatment. It has implications for improving access and utilization of cancer screening. What we've been focusing on within our center is, how do you build that out and build and implement a more sustainable strategy by linking primary care. And we're doing that with federally qualified health centers in Los Angeles County to really bridge sort of primary and specialty care as it relates to using patient navigation. So we've established 3 different types of navigation pathways. One focused on outreach, which is primarily has the goal of sharing evidence-based information with community stakeholders in Los Angeles County. This is where our geospatial collaborations are really important, because we use the information about cancer hotspots for cancer disparities, rather, to sort of prioritize where and how our navigation team are deployed to provide outreach and education about cancer risk factor screening and control. We're also working within our healthcare system to address utilization of screening for breast, cervical, lung, and colorectal risk. Again, building on sort of the past empirical studies, which have shown us that population-specific or evidential information about cancer risk factors and outcomes among that are targeted to that particular population has greater benefit than information that's just provided. Cancer is a really bad disease, and it's sort of more generic information. And the other thing that we're incorporating across, and then treatment navigation, is really about working within our healthcare system to work alongside the nurse navigators who are really focused on addressing sort of clinical access, moving patients from one stage of treatment to the other, but don't really have the time to address sort of the social issues, the social drivers that are important. So this, across all of the 3 domains, is we incorporate a navigation to address social issues, and we call it social determinants of health, but it's really social stressors navigation, because it's really about identifying patients who and community members who are experiencing financial strain, who are having high levels of stress, who are experiencing social isolation that leads to some very concrete barriers related to transportation, that's related to concrete issues related to being able to cover the cost of care. And using our navigation team to address those issues using a systematic protocol. We've also begun to implement strategies to really change the way in which our navigation systems work across the Keck Medicine of USC and the Norris Cancer Center. So just as I illustrated with these 3 domains of navigation, you can think about 3 different types of navigators who are working. So there's the nurse navigators, there's the outreach team that's working as part of our Office of Community Outreach and Engagement. And then there are also like practice-specific navigators that are working within the context of like individual practices to help patients get from one thing from point of care to the next. That's great. But where we sort of might have a breakdown and an opportunity for improvement is that they don't talk to one another. And so we've established a multidisciplinary navigation forum that's designed to bring the different navigators, stakeholders together to talk about, well, this is what we do for our vision, our sort of delivery of navigation. This is the other team can say, this is how we do it in our sort of realm of responsibility. And through those shared conversations and discussions, we're able to centralize and integrate navigation more effectively. Because ultimately, navigation is, at some point in time, is about handing patients off to the next care. Where patients can get handed off is where we sort of have a risk for losing patients, which ultimately reduces the quality of care that's delivered. So this is our vision, how we're sort of our workflow for navigation. And you can see, we've sort of worked to sort of think about the system from outreach to screening to treatment and care. And our RLC navigation team is sort of shown here because we are part of the Norris Cancer Center, but we really work across and together with our outreach and screening navigation. So it's a work in progress, and I'm really excited about it because it's a new way of delivering care that we're sort of bringing a way that's we're thinking about actionable and sustainability as we work towards implementing these services. So I'll bring my comments to a close just by saying, I think we still have a lot of opportunity to understand the effects of multi-level social determinants on cancer health disparities. I think we're just scratching the surface, and I think we're sort of have started with social stressors, but we'll begin to understand more about environmental drivers and other characteristics and other variables that are important. And just to emphasize, the work that was described about the Voices study, we do need to have those resources, available to us to really begin to generate the empirical evidence that will inform, our thinking and action. Part of what I think we also have, as I just illustrated, that we do have some things that we can start with. And our Ralph Lauren Center is one example of, working with, community partners, integrating and building that bridge with primary care to specialty care, but also deploying a new type of navigation to be focused and target on social issues. So this is all part of a transdisciplinary team that I have the great fortune of being a part of, my own research lab, but the navigators are shown here. And I'll just end by thanking, all this makes possible because I'm here with the support of my family, and the institutions that have, been a supporter, a sponsor of the work that we do. So thank you very much.